So we're going to talk about how to manage that rapid response patient before you transfer them or while you're waiting for the transfer. And sometimes waiting for us to get there takes a long time. And I'm going to talk about why that takes a long time and like what we're all doing. So a lot of times people think because we have a couple teams stationed here that they're just here, sitting here, and they're not. So our MICU teams, a MICU team, a mobile ICU, is a team that's comprised of a critical care nurse, a critical care paramedic, meaning that they are board certified as a critical care paramedic, and an EMT. So from 7A to 7P, and then 7P to 7A, we have a MICU team based out of here. We also have one from 10A to 10P at Westchester, and then one from 8A to 8P at Butler County Airport. So you can see we kind of ramp up as the day gets busier, and then we ramp down until nighttime. So from 10 at night until 10 in the morning, we have one team on, or 8 in the morning, we have one team on. So how many MICU transports do we do a year? Over 1,000 transports a year. So you can see where the team is busy doing transports and why they may not be able to be here right away. So now let's talk about what you do with your patient or how you can handle these patients, either when the event's happening or before we get there. So, and think of this as your rapid response patients. And you guys, you do have a rapid response. You do rapid response here? Okay, all right. So it's always a systematic approach. So BLS, ACLS, PALS, anything you take, there's always, everybody's doing the systematic approach. So we're all on the same page. So the one thing you want to look at or check is their airway. And if the patient's talking to you and they're awake, they have a patent airway. But the way to ascertain if they have a patent airway. And check their breathing. You want to know how well they're breathing. And then the circulation. Some specific things that we want you to think about when you're assessing somebody's circulation is what is their blood pressure? What is their heart rate? Have you done a 12-lead ECG? What's your temperature and what's their glucose? And I'm going to go into where some of these things can tell you really what's going on with the patient as we move through this presentation today. And then you need to know the differential diagnosis. You need to be thinking about what is wrong with this patient so that you know how to treat this patient. Or when the physician gets there or arrives, you can say, hey, this patient, their blood pressure is da-da-da, and their potassium is 7.8, they're hyperkalemic, I think that's the cause of the situation here, we need to treat this. So that you have a definite plan of what's going to happen. So when we look at differential diagnosis, there's some things that will help you develop a differential diagnosis. And the one thing you have to get from the patient is their history. You need to know what's going on with the patient to kind of start down the pathway of what might be going on with them. And then H's and T's. So how many people here have had ACLS? Just about half of you have had ACLS. And H's and T's is a huge part of it. And anytime, really, if somebody's in a PEA arrest, the only way to reverse that, really the only way, is fixing what caused it. And you have to, that's when you go to your H's and T's. Epi may give you some time, but Epi will not cure PEA. Fixing the causative factor is what will cure PEA. Epi's your bridge until you get the cure. And then perfusion. So we're going to talk about these more in depth. So when we talk about history, you want to get a focused history. That's one way to ascertain what's going on with the patient. That's with specific questions. Another way that we may use a down and dirty quick way to get down to what might be going on with our patient is to use SAMPLE. And that's an acronym, and what SAMPLE stands for is S. What signs and symptoms are they exhibiting? And then A, do they have any allergies to medication? And why you want to know that is when you think about your S-bar and you're talking to the physician and you're saying this is what's happening, you need to know what allergies your patient has and what medications they're on in case an order comes up that counteracts what you're asking for. Or allergies to medication could be the causative factors, so you need to ask for those. So allergies. And then M will be your medications. And then P is pertinent medical history. What brought you in here today? Why are you admitted to Drake Hospital? They may give you the laundry list of what their whole medical history is, but even knowing specifically why they're here this time is very, very useful. When was their last oral intake? And again, that can tell us a variety of things, but it's also kind of nice to know if you have to intubate them, how long ago do they eat, are they going to be vomiting, or, you know, I haven't been able to eat for 2 days. Okay, that might tell you something more about what's going on with this patient. And then the events leading up to the incident. What happened prior to this event happening with the patient? So once you have that information, you may be able to start making that differential diagnosis. So we talked about history. Now we're going to talk about your H's and T's. So for those of you who have had your ACLS, one of the H's is hypovolemia, low blood volume. That's typically what we think of when we think of hypovolemia, is low blood volume. And your patient's initial physiological response when they are hypovolemic, be it from low blood volume or because they've had vomiting and diarrhea and are dehydrated, is the body is designed to compensate anytime there's an assault to it. So if it's hypovolemic, the first thing it's going to do is it's going to increase the heart rate. It's trying to do that to increase the cardiac output. So it's going to increase the heart rate. So if you were to look at their monitor or an EKG, you're going to see rapid narrow complex tachycardia on these patients. What also is going to happen is as the systolic pressure, the diastolic pressure is going to start to increase. This is that compensation again. The body is trying to increase the cardiac output, and so it does that by vasoconstricting out into the periphery to bring up the diastolic pressure to help increase the cardiac output. So when people's skin is cool, when they're shocky, that's one of the reasons why they're cool, is because the peripheral blood flow is being shunted to where it needs to be. So I'm going to have that increasing diastolic pressure. And then my systolic pressure is going to fall. So what you're going to hear people may talk about is a narrowing pulse pressure. And so my pulse pressure is my systolic pressure minus my diastolic pressure. And that is the first sign you're ever going to see on your patients when they're in shock. Before their blood pressure, before you notice like hypotension, you're going to see a narrow pulse pressure. I can lose like 30% of my blood volume, and I might be a little tachycardic. My blood pressure is going to appear to be normal, but if you track my pulse pressure, you're going to see that it got narrower and narrower, and that can be your first sign that there's something wrong with the patient. So eventually the blood pressure falls, and then you can't feel the blood pressure or pulse anymore, and they go into PPA arrest. So that's your hypovolemia H. So just kind of an example. So there's a couple different things too that will happen with this pulse pressure, that if it's wide or narrow, because the body does different things depending on what the source of the assault is, will change. So if I have a blood pressure of 70/55 or 70/35, both are crappy. I don't like either of those blood pressures. But what's the difference between those two? Well, here's the difference. 70/55 is technically a lower systolic and a higher diastolic. So I have a low cardiac output, but my systolic vascular resistance is maybe a little bit higher at that point in time. 70/35, now I've got lower systolic and lower diastolic. So I've got low cardiac output and low systemic vascular resistance. So what does that mean? Yeah, that's our pulse pressure. So if I have a wide pulse pressure, that's at 70/35, right? So 70 minus 35, somebody do the math for me, but it's
35.
Yeah, what was it?
35.
35, okay, so 35, all right. Those people are probably going to be the septic people or may have a Cushing reflex. So sepsis, if you remember with sepsis, what do? They vasodilate. That's part of the histamine release and everything that happens with the body with sepsis, so they get this vasodilation. So that's why you're going to see this widened pulse pressure for these people. And even though they're hypotensive and in shock, they have a widened pulse pressure. The narrow pulse pressure are going to be your people with hypovolemic shock or maybe cardiac tamponade. So just so if you're looking at your patient and you're seeing that patient who's got the 70/35, a widened pulse pressure, that may be your septic patient. So that's a person, urosepsis, sepsis from their pneumonia, sepsis from the flu. We're seeing a lot of those patients. So when earlier I was talking about shock and the classifications of shock and how, oh my God, sounds so better. How I got class 1, class 2, class 3, and class 4. So if you're looking here at class 2, because in class 1 everything seems to be kind of normal. It's okay, they're kind of hanging out there. But class 2, where I started to see changes, and I could lose up to almost 1,500 liters of blood, or 1,500 milliliters of blood. And that my blood pressure is normal, but my pulse pressure is narrowing or it's decreased. So again, this is where you can use this for signs of shock, or classifications of shock. Now hypoxia, another H. So this is just when the oxygen cannot reach the body's tissues for whatever reason. I can be hypoxic because I have a collapsed lung. I can be hypoxic because I have pneumonia. I can be, there's just a variety of reasons why I'm hypoxic. And the heart rate slows as in a response, and I have decreased cardiac contractility, and I go into PEA arrest. So cueing into this and correcting this again for that PEA arrest. So if I have bradycardic PEA arrest, this is one of the things I'm really thinking about. Are they hypoxic? And is that the causative factor? So when we're looking at these people who are hypoxic, so how often do you guys have a lot of pulse oximeters here? You get to use your pulse oximeters. So when you have a patient on a pulse oximeter and the pulse ox is 92, are you comfortable with that? So she said depends on the patient. Yeah, because if they're always there, they're always there. So the one thing that people will develop a false comfort with their pulse ox is because they're thinking the pulse ox is like the PaO2 in their blood gas. And it's not. Two different things. My PaO2 and my blood gas, the normal range is 80 to 100. So I'm going to give it here so you can see better. So we call this the oxyhemoglobin dissociation curve. So this is my PaO2 down here. This is what you would see on the blood gas. This is my SaO2. This is what you see on the pulse ox. So if my PaO2 is at the end of normal range, 80, my pulse ox is about 94%. Right. So if my PaO2 is in the 60s, now I'm below 90% on my pulse ox. So that's telling you that your patient is hypoxic and how it quickly falls. So when you start to get over here like this, if it's not reversed real quickly, your patient's going to go into cardiac arrest because they're going to be so hypoxic that they can't function. The body cannot compensate for this, and they go into the PEA arrest. And so that's why with our pulse ox, we want it to be 94 to 99%. The opposite end of 99%. So we never want it to be 100%. And the reason for that is if I have my pulse ox at 100%, I have no idea what my PaO2 is, because I can have a PaO2 of 400. Because 100%, just that's it's at 100%. I can't tell anymore. So through studies, through research, they have found that oxygen toxicity exists. So if somebody has too much oxygen, it is really bad for them. So as a result, we try to keep our pulse ox between 99%, because I know at 99% that I'm like about 100% on my PaO2. So 99%, 94%. That's our range for a pulse ox. That's our normal range. Now the next thing is another H is hydrogen ion acidosis. So when the body starts to build up acid and hydrogen ions in the blood, it will launch this ischemic cascade. And this hypoxia starts to increase anaerobic ATP production, which then causes lactic acidosis. So a lactate is a blood test that we love to use to tell us how bad the patient's doing. And greater than 4 is bad. Now, if your lab can't do a lactate, we have a thing called a poor man's lactate, and it's called your glucose. So your glucose, if your patient's not diabetic, all of a sudden their glucose is elevated, that could be their way of telling you, hey, I'm getting septic, or hey, something's wrong with me. So you can use that glucose as a poor man's lactate. Now when all this lactic acidosis is happening, your ventricles start to stiffen as a result. And when your ventricles get stiff, they can't compress as well. They're not contracting as well anymore. So you're going to have a decreased diastolic fill and a decreased cardiac output as a result. And so again, blood pressure falls, and they go into this PARS from it. So on the EKG, if you were to get your EKG on that patient, what you might see is their QRS complexes may have a smaller amplitude, so they may be smaller on your 12 lead, and that might be your Q. And they can develop potentially lethal arrhythmias, PARS. 2 more H's are hyperkalemia and hypokalemia. So on the ECG, with hyperkalemia, you may see peak T waves or flattened P waves. And with hypokalemia, the T waves start to flatten, the P waves become more prominent. They can also develop a wide complex tachycardia. So here's just some pictures of a QRS, or P wave, QRS, and T wave. Here's your ECG complex. This is normal, what we expect to see. With hypokalemia, see how my T wave is kind of flattened here? And then with hyperkalemia, my T wave is more peaked. And then just with hypocalcemia, it was kind of flattened here. And then with hypercalcemia, I hit this little divot here. Hypothermia, another H. So if their temperature is 95 Fahrenheit or 35 centigrade, and you're saying, well, gosh, we shouldn't have a patient that cold here. But it can happen. People who have hypoglycemic reactions can get hypothermic. So it's just putting it out there for you. On the ECG, they may have what they call a J wave or an Osborne wave. And this is just a picture of an Osborne wave. And this patient was an atrial fib, and they were bradycardic. And their QT interval was prolonged, and when they got their core temperature, it was 76 degrees Fahrenheit. And actually, this is the kind of time of year, actually, where we see people who are more hypothermic. When it's not really cold out, because when you're cold out, people tend to be dressed warm. But when they're not, it's not so cold out, you let your guard down, and people can get hypothermic in this kind of weather, especially with it being wet. Now we're to the T's. So tension pneumothorax, and this is where air starts to enter that pleural cavity and it cannot escape. Normally, to keep my lungs kind of in a semi-inflated state where they're in your chest cavity, you have -4 millimeters of mercury of pressure in your chest. And if anything disrupts that, you lose that negative pressure. And it can happen because I got a hole in my chest here from trauma or whatever, and now air's coming in from outside, causing a positive pressure. Or I have a hole in my lung. So this can happen to your COPDer who you just intubate, and now you're ventilating them with your bag valve mask and maybe bagging them a little vigorously, and you pop a bleb on them, and now I've got a hole in my lung. So every time I ventilate that patient, air goes into the lung and then out into the chest cavity, and causes that pneumothorax to happen. So with the tension pneumothorax, it just builds and builds and builds, and then eventually I've got all this air in my chest, and it's pushing my lung over, pushing my heart over, and eventually my trachea moves over. So people may talk about tracheal deviation. Typically, people are catching on to what's going on with the patient before this happens. But if they develop attention pneumothorax and it goes untreated, they're going to go into PEA arrest because my heart can't fill with blood. I'm squishing my heart now, and it can't fill with blood. My cardiac output falls. I go into PEA arrest. I thought the cartoon was kind of good for attention pneumothorax. So they're showing air coming in from outside of the lung, or outside the chest cavity into the lung. So as it's filling in here, it's squishing the lung, and then eventually pushes over and squishes the heart. And so what needs to happen is they either need to have a needle decompression, just real urgent, emergently, to just quickly fix the situation, followed up with a chest tube. A needle decompression is only going to last you for a short period of time, so it has to be followed up with a chest tube. And so we recently had a patient that we transported from Westchester down to base, and I can't remember what the patient's diagnosis was, but they were on a ventilator. And so people who are on ventilators have a good chance of getting a pneumothorax because they're putting positive pressure ventilation into their lungs. And it's a good way to cause a blood to break in somebody's chest. And so the team was transporting them down. The patient was deteriorating as they were driving down the road down to the hospital. And then by the time they got to the hospital, it was like, I know what's going on now. So it's like as they're wheeling into the ER, we need a needleless chest, to tell the team this is what's going on with this patient. But they were assessing and they were trying to troubleshoot. They were going through their H's and T's as to what's going on with my patient. And then finally they're like, this is what's going on with the patient. And like when you're driving in the back of the ambulance or flying in a helicopter, you can't hear breath sounds. So that's off the table. You can hear hyperresonance when you're percussing. So that's off the table. You're basically looking at your vital signs and you're seeing that they're hypotensive and they're hypoxic and you're trying to figure out why. And you're going through your H's and T's, your differential diagnosis to figure it out. Tamponade. So this is cardiac tamponade. So this is accumulation of fluid in the pericardial sac of the heart. With a trauma patient, when you think of a cardiac tamponade in trauma, it just takes like 75 milliliters of blood in the pericardial sac to create like a band-like effect around the heart, and the heart can't fill with blood, and it's real stiff. Not likely for you to see that here, but the ones you are likely to see here, and they can just slowly creep up on you, is the pericardial effusion. And these are people who they just build this fluid in the pericardial sac over time, over a month, 2 months, and they're tolerating it, but they just may notice that they're getting a little bit more short of breath, and their sats are starting to drop a little bit until finally they get really sick. And when they go and they do a chest X-ray on these people, get a picture. This is what their heart looks like. So if I do do a pericardiocentesis on this patient, I could draw probably a whole liter of fluid on this patient. So let me go back a second here for the pericardial tamponade. So these people are going to have a rapid heart rate with a narrow complex. That's the one thing you're going to see with them. And so basically what this picture is showing is they're going to put a needle in the heart and try to draw that fluid off. The other thing is they can have Beck's triad and basically hypertension and distended neck veins. And in my entire career, I've never seen that. I've had people with pericardial effusions, and pericardial tamponade, and I've just never seen the Beck's triad. But it's something you can have. And muffled heart tones. And again, it's so hard to hear that stuff when you're, everything else is going on, these other noises are going on. So, I can do my chest X-ray. And the one thing when you look at this heart, if you remember your old hot water bottle heaters, see how it's kind of this little notching up here? Kind of looks like a hot water bottle heater, or hot water bottles. And that's one of the classical things you'll see with pericardial effusion is it looks like a hot water bottle. The other thing to look at is with your ECG. They have this thing called electrical alternans, and what that means is my QRS complex is changing the size of it because of this. So you'll see here, it's longer, shorter, longer, shorter, longer, shorter. When they talk about electrical alternans, that's what they're talking about. And that's this pericardial effusion that's causing this. So there's my hot water bottle. Soon we're going to have a whole generation of people who won't know what that is. Alrighty. Then toxins. So these are, a lot of times people think of drugs. It could be plants, it could be a variety of things that can cause a variety of oddities to your ECG. Just depends on what they took or what they got into. Or medications interacting poorly with each other. So what I have here is, so bradycardia may be one of them, and a prolonged QT interval is another one. And that's what I'm showing you here is this prolonged QT interval. So my complexes look wide and weird and what the heck's going on with this patient. But it's through all of my leads, which is leading me more to think that it's maybe a drug situation or a toxin. And you want to get that focused history so that you know what's happening with the problem in here and what medications are they on and what did they get into that may have caused this. The other T is your thrombosis, coronary thrombosis. And this is when you do your 12-lead ECG. And you're going to want to look and see, do I have ST segment elevation, or do I have an end-STEMI where I don't have an ST segment elevation? And I'm going to show you how to do a quick down and dirty read of a 12-lead ECG. So this is my normal complex. I got my P wave, my QRS, and see these are my baselines here. So everything is, there we go. Everything's come down to baseline. This is my ST segment, and it's baseline. This one you can see my ST segment is very elevated. So it's like this is P, Q, R, S, T. Right. So ST elevated here. That's my STEMI, my ST elevated MI. This is an end-STEMI where it's just slightly inverted a little bit with a little bit of depression. And then this is an end-STEMI where it's an inverted T wave. So the end-STEMIs are a little harder to determine. But for me to say it's a acute MI, I have to see ST segment elevation, contiguous leads of the ECG. So when I talk about contiguous leads, what do I mean? So it goes in order. So V1, V2, V3, V4, V5, V6, then 1, 2, 3, and AVF. The AVR and the AVL are looking at it from a different angle. So they're like reciprocal. So like 1 and AVF are looking at it like this. So just looking at it reversely. So if I have ST elevation and 2 or more leads, so I start to have it there but not really right there. I got ST segment elevation there, but these are the 2 contiguous leads. So okay, I can't call it an MI right there. I've got it here and here, so now it's in 2 leads, 2 contiguous leads, and I can call this an MI. But what MI do I want to call it? Because it could be anterior, it could be septal, it could be inferior. Here's an easy way to do it. We call it Sally. So V1 and V2 is S for septal. A is V3 and V4. That would be anterior. L is V5 and V6 for lateral. And then the other ones are inferior. So 2, 3, and AVF are inferior. So just as a way, an easy way to remember when I'm looking at my 12 lead, where this heart attack may be coming from, think about Sally. So V1, V2 is S for septal. V3, V4 is A for anterior. V5, V6 is lateral. And then 2, 3, and AVF is inferior. Alrighty. So, the other thrombosis, pulmonary. Blood clot in the pulmonary artery. They're going to have narrow complex ECG. They're going to have a rapid heart rate. You're going to see hypoxia on them. Then they just need to be transported. There's actually a new treatment out there. We just started transporting patients recently. It's called ECOS. And basically they put a catheter in their femoral artery and they go up into the heart with it. And they have this ultrasonic pulsating heparinized solution that's going at it to help take care of their clots and things like that. So we just started transporting patients on that from Westchester and some of the other hospitals. So it's kind of a new treatment. And then one of our APNs actually had it on her. She had that clot. And she said it was kind of an uncomfortable feeling. You could actually feel it. So when she told us that, we're like, okay, so that's something to think about your patients. It's uncomfortable, so make sure you're medicating your patients to take care of that anxiety and comfort that they're going to have with that. So let's come back to our systemic approach, our differential diagnosis again. We did histories, we did our H's and T's. Now let's talk about perfusion. And all this kind of ties together. So when we look at perfusion, years ago, I took a class called ACLS-EP. It was for the experienced provider. And really what it was rapid response. That's what it was. It was taking care of that patient before they got into the cardiac arrest event. And what they did was they broke it down into a thing called tank pump rate. So when you're going to your rapid response, another thing to do is think about tank pump rate. Well, what am I talking about, tank pump rate? It's your perfusion again. It all has to do with perfusion. Getting these vital nutrients, blood and oxygen, to my body and tissues. So, volume. My intravascular volume. Is my tank too full, or is my tank not full enough? So, I can have, so for, like say for hypovolemic shock, I've lost my blood volume, or I've had vomiting and diarrhea, so I don't have, my tank's not full enough. Or, am I in anaphylactic shock? My volume's normal, but my tank is now too big. So, there's your tank situation. Think about your peripheral vascular resistance as well. But then pump. Is my pump working right? What's the strength of my cardiac or my heart muscle in pumping? And then rate, heart rate. Is my heart rate too fast or too slow? And if you break it down like that, and if you think about most of your patients, when you go to rapid responses, you can kind of break it down into these four little things: tank, pump, rate. So, cardiac output, it's your stroke volume times your heart rate, and I've talked about this earlier today. So when my cardiac output starts to fall, my heart rate tries to pick up to correct it. So ideally, if my heart rate goes up, my cardiac output should go up. Ideally, that's what should happen. So if I'm exercising and I'm a healthy person, that's what happens. My heart rate goes up, but I still have a good working heart and things like that, and I got a good blood volume, so my cardiac output will increase, because it will need to, because it's got to perfuse me since I'm exercising. But if something else happens to affect the other factor, the stroke volume, because I don't have enough venous blood return to my heart, that's your preload. So people who have vomiting, diarrhea, blood loss, affecting their preload. The strength of my heart, the contractility of my heart is being affected. That's going to affect the stroke volume. The resistance against the blood, or the resistance of which my heart is pumping against. The afterload, again, that's affecting my stroke volume. The body compensates by changing heart rate to fix that. So just a nice little picture, preload dumping in, afterload being squeezed as it's trying to get out. So what are causes of decreased preload? Bleeding, dehydration, pulmonary embolism, tamponade, and attention pneumothorax. Then things that are affected by afterload is anything that might cause a resistance to the blood flow out of the left ventricle. So the things that we typically can see is some tamponade can affect that, but aortic stenosis, somebody's got a stiff aorta, can affect that. And sepsis, because they massively vasodilate, or anaphylactic shock, they massively vasodilate. Things that affect my cardiac contractility. So if I'm having acute MI or I'm having heart failure, this can affect the contractility of my heart. So I'm going to have low or no cardiac output in those situations. So if we think about perfusion issues due to a decrease in cardiac output as the cause, we can use this this little, what do you call it? Circling the drain type of thing, because that's what's happening here is, first I start here, I've got poor perfusion, which causes systemic ischemia, or oxygen death due to hypoxia. Well, when that happens, we start to shift to the anaerobic metabolism. Remember that ATP and the lactic acid. So we accumulate our lactic acid, and when that happens, we become more acid, or the pH becomes more acidotic, and our contractility decreases as a result of that. Well, this reduces your stroke volume, which now triggers more compensatory mechanisms, and it increases your afterload. It's trying to fix things. Well, this ends up decreasing your cardiac output, and now you have this blood that's sluggishly moving through the cardiovascular system, which results in poor perfusion. And it's just, the cycle just goes around and around, and you gotta break the cycle. And so when you have this blood moving sluggishly through the body, this is where people end up in what they call MODS, the multiple organ failure or dysfunction. It's because of this happening. So we have to break the cycle, and we have to stop it earlier in its phase. So now we're going to give you a couple case scenarios. And these are actually patients we actually picked up here and transported out of here. So you're called to a room of a 63-year-old female who developed nausea and vomiting an hour ago and chest pain about 30 minutes ago. You're in that room now. So what are your initial actions? What do you want to do when you get to that room? Check her airway. Good. All right. Yes. Airway.
Breathing, circulation, do your ABCDs.
Right. Vital signs. Good. ABCD. Your vital signs. Differential diagnosis. So we do an ABCD survey, and during that we get her blood pressure, and it's 80/40. Her heart rate is 110. Her respiratory rate is 20. Her O2 sat is 90% on room air. Her temp is 98.6, and her glucose is 104. You know, and a glucose is really important to get, especially if they're hypoglycemic. I shouldn't say crucify. If our teams ever intubate somebody, they better have a glucose documented before they intubate that patient, because it's really embarrassing when you intubate somebody and you get them to the hospital and the emergency department checks a glucose and it's 25, and they give the patient D50 and lunch, well, extubate them, and then give them lunch and they walk out. And it's happened a couple of times, so it's a big red flag for our team. You have got to check a glucose, and they have the ability to check glucoses. We have the Accu-Check, and we have EPOC. They can check a glucose. It's drilled into them, but every once in a while someone forgets. And then sample, do your differential diagnosis. So on her situation, she said for simple symptoms, she had nausea and vomiting, chest discomfort, tachycardia, and hypotension. Allergies, she has an allergy to shellfish and codeine. For meds, she was on insulin, hydrochlorothiazide, and some vitamins. For past medical history, or pertinent medical history, she's diabetic and has hypertension and a CVA. She last ate 4 hours ago, and events leading up to this is nothing to report, just this nausea and then the chest pain. You've all had this patient, haven't you? So let's do our H's and T's. Is she hypovolemic? I think she's just not, maybe she did have some vomiting. So it's possible with the nausea and vomiting, but she's receiving IV fluids. Okay, other causes? Could she have occult bleeding? Yeah, because you get a patient with a GI bleed and they bleed enough, they can have an MI from having, losing too much blood. Hypoxia? Yeah, right. Her SAT was 90% on room air, so it could be hypoxia. Because you want to know, why is her SAT 90% on room air? What I gave you as a diagnosis really shouldn't tell you that, for that kind of a SAT. So you want to be, investigating that further. Hydrogen ions. So her respiratory rate is 20. So if she was breathing too fast, they're gonna blow off their CO2, which can affect their pH and their blood gas. Or if they're breathing not enough and they're hypoxic, it will affect their pH as well. That's why I put it right there. Hyper or hypokalemia. So you can see her labs, see if that's an issue, but nothing in her history told me that. However, she's diabetic, so she could have some renal failure or early renal disease. Hypothermia. No, her temperature 98.6, good, right? So, now we look at our T's. Tension pneumothorax, lungs are clear, tamponade, doubtful, toxins none noted, thrombosis pulmonary. It's a possibility. She's got chest pain, and she's hypoxic, so it's a possibility. And then thrombosis coronary. The only way to would just do a quick 12 leads. It's going to tell us more than anything else. So we talked about we do the tank pump rate thing, the intravascular volume. Is her volume depleted with a blood pressure of 80 over 40 and a heart rate 110? It's a possibility. Peripheral vascular resistance, her skin is cool and clammy. Cardiac contractility, can we get an echo? That would tell us how well the heart's contracting. Heart rate is 110. Let's check the rhythm. So we're going to get an EKG. So think back to my Sally that I told you about. So where do we see ST segment elevation in this patient?
V3, V2.
So we got V2, V3, V4.
V4.
Okay. So what was V1 and V2? S, septal. All right. But this is really, I don't call that really an ST elevation at this point in time. Because the takeoff is still kind of in the normal point. It's starting to get there, but it's not there. So I would need V1 and V2 to be elevated for that to be a septal MI. But V3 and V4, they both have elevations. All right.
Anterior.
So what were they?
Anterior.
Anterior. So right now I'm saying she's got an anterior MI. So we have V5 and V6. Maybe a little elevation here, but none here. So right now we can go with an anterior wall MI on this patient. So, the left anterior coronary artery, the LAD, left anterior descending, supplies the anterior wall of the heart. So when people talk about the widowmaker, this is the one that would be that widowmaker, all right? So if you have a proximal occlusion, this can affect a major part of the myocardium. So these people with these MIs need quick intervention. That 3-hour time, the 90-minute door to needle kind of thing, or reperfuse. So if you're having that patient that's having this pain and you do the 12 lead and you see this, you gotta be thinking we gotta get them transferred right away. Right away we gotta get them transferred because they need reperfusion. But what you can do in the meantime is you can give them aspirin if they're not allergic to it. You may be able to get a heparin bolus for them, whatever your protocol is. But our teams will try to make sure that they have aspirin, heparin. So if you get them aspirin and you have them on a heparin drip, and our team comes in, they have this rapid extrication protocol. It's called Code STEMI, where they may just take the IVs and throw them in the patient's lap and go. They won't even put the IVs on a pump. They'll clamp them off. They just want to get them down to the hospital as quickly as possible. Because by the time they go and they get all of our lines plumbed and everything like that for the patient, flushed and ready to go, we wasted maybe 10, 15 minutes doing all that stuff. So it's dump everything in their lap and get them going. And we check our charts and we audit those charts and we look to see how quickly our teams are moving these patients into the hospital. And outlying hospitals understand that they can send a patient to UCMC with no doctor, with no accepting, which would be kind of an EMTALA violation because of this Code STEMI. We don't want hospitals wasting time trying to reach a doctor who will accept this patient. They need to go to the cath lab. So and that's been proven to really save a lot of lives by doing that. So these people are also at risk for cardiac or congestive heart failure and cardiogenic shock, because if I'm infarcting a major wall of my heart, what's going to happen to that wall? not gonna move very well, my pump's not gonna work very well. So for these people, you gotta be careful with your fluid administration. So if they're hypertensive, you may just give them 250 bolus of fluid. Enough to just kind of give enough for it to be able to pump against, but not enough that it just floods it. Now this patient's having runs of VTAC, and then VFib, and then cardiac arrest. Why aren't you here faster, NICU? So you start to do your CPR. And when you do your CPR, again, we're back to that systemic approach. Now, so really it's C, ABC. So what do we start with first? Yes, compressions. And somebody's bringing me what? A defibrillator.
Oh.
Right, yes, right. Lunch, a defibrillator. Because energy is what they need. They need electricity to try to fix that. So somebody's doing CPR, somebody's bringing the crash cart with the defibrillator on it, and then my third person can start to work on ventilating the patient. So in this situation, the RT was not patent. The RT attempted to intubate ×3, and then finally they got an iGel inserted. So do you guys use iGels or King Airways? What do you have as like a backup airway?
iGel.
iGels, okay, which are real simple to put in, and the heat of the body just kind of creates a nice seal, and they're easy to work with. So then breathing. You're going to assist with the bag valve mask, and when you do that, you hear coarse breath sounds. You do see symmetrical chest rise and fall, and they're set at 94%. So that's all good. Now they can't be in VFib if you see a sat of 94% because they have to have a pulse to see a pulse ox. So remember, they're in and out of VFib arrest. So when you're ventilating a patient, you need to be careful to not overventilate them. So that really when you're counting like every 6 to 8 seconds, you really need to go 1 100, 2 100, 3 100, 8 100, ventilate, and so on. So that you don't overventilate them if you're just ventilating them. Now, if you're doing the compressions, you're going to do 30 to 2. Or if you got the iGel in, somebody's doing over 100 and you're doing every 6 to 8 seconds. Circulation. So they're having these runs of VFib, pulses VTAC, and then they go back into sinus TAC. So they're in and out of these rhythms. When they do have sinus TAC, the blood pressure is 103/70, the heart rate's 130, the respirators are 18. Skin is pale, warm, and dry. So what's our differential diagnosis on this patient? What her ECG show us? Right, she's acute MI, now she's having runs of VFib, VTAC. So, I mean, we did the history, the H's and the T's, the perfusion on her. We did our tank pump rate. Is her tank too full? Yep.
No.
Is her tank not full enough? Is it her pump? It's her pump, definitely. And is it her rate? Yeah, so it's her pump and her rate. The tank pump rate, her tank maybe too full or not full enough, we're not quite sure. But her pump's not working right, and her rate's too fast with that VTAC, VFib. So with the runs of VFib and VTAC, we have our nice little pulsus arrest algorithm that we follow from American Heart. So in this situation, we are going to go down the VFib, VTAC arm of the algorithm, and we want to shock. What is your defibrillator here?
LifePak.
LifePak, okay, and that goes with 360, correct? So if you do, I don't know, what do you?
200, 300, 360.
Okay, all right. So that's what you'll do. We have Zoll, so we just do 200, 200, 200. That's why I always have to ask what everybody has.
200, 300, 360.
So you'll do that. You'll do your shock one time, you start doing immediate CPR. And while that CPR is happening, you need to start planning for that next break, in that 2-minute break. What's going to happen in that 2-minute break? So in that 2-minute break, am I going to give epi during that time? Am I going to do epi and shock the patient? Am I going to shock the patient, then give the epi? Am I going to get amiodarone? So be planning. So in the initial, I see my patient going to VFib, VTAC, pulses VTAC. We're starting compressions. As soon as somebody brings me a defibrillator, I'm shocking the patient at that. And what I'm telling my team is, as we're going to the next 2 minutes, drop some epi, get some epi ready. Go ahead and charge at the defibrillator to 300 joules. 2 minutes we stop, we look. We're still in VFib, VTAC. Shock the patient at 300 joules, start CPR again. Go ahead and give that epi now. Then in my next 2 minutes, I'm going to get it, I can go ahead and drop amiodarone, 300 amiodarone, get it ready. I'm going to charge up my defibrillator to 360. 2 minutes, we stop, we look at the monitor, still VFib, VTAC, shock, start your CPR, give the amiodarone. Then I'm going to be thinking for the next break, what am I going to do for that next break? I'm going to get my epi ready, I'm going to charge up my defibrillator. And so that's what that 2 minutes is for. It's to plan for that 10-second stop. And at the end of 2 minutes, what you're going to do. So you get your defibrillator charged up. So when you stop, you look at the rhythm, and you don't need to do a pulse check. If they were in VFib and they're still in VFib, I'm not wasting time checking a pulse. I still see VFib. I'm shocking that patient. Get right back on the chest with compressions, then give your medication. So we go down the algorithm, and we can do all that stuff with the algorithm. And as you're doing it too, you're also thinking about your H's and T's. What's caused the situation? For her, we know she's having an MI, so we need the MICU to get here to pick this patient up to get him down to the hospital so she can get reperfused. And we're actually even thinking, we're trying to see if we can start to carry a TPA on board on the ambulance. That's really expensive. So we gotta figure that one out. So we get her pulse back, and now she's ROSC. So return of spontaneous circulation. So now what do we do? What's with that? What do we want to do? So when we have return of spontaneous circulation, we need to think about our airway and our perfusion. So we want to optimize our airway. We want to make sure she's satting well. We want to make sure their blood pressure's fine. Treat any causes that we can. Check their glucose, etc. And then down at the bottom, it talks about neuroprotective care. So what that's saying is, if this patient is not responsive to you, they got ROSC, but they're not awake and alert, they're not responding to you, that we do hypothermic protocol to check the brain. And if you can't start it, we have the ability to start it. We just ice packs, basically. We'll get it started and try to get the temperature down to 36, 35 centigrade. So in her situation, we get her ROSC back. Her airway is optimized. She's got an iGel in place. She's at 94%. I'm good with that. We monitor her blood gases. We can monitor capnography. Do you have the ability to do capnography here?
Waveform capnography?
Yes.
Yes.
Okay. So in the middle of a code, if you can get the capnography on, like end of your iGel, first off you want.
They use the EMAS,
Okay. All right.
and it has that waveform.
Okay. Good. So one way to use your capnography is to tell you how good your compressions are. So I need to see at least like 12 on my capnography waveform to tell me if my compressions are good. You're going to see a jump in your CO2 and your capnography before you actually get a pulse back on the patient. So if I'm at 12 and all of a sudden I start to jump up to 20, 25, I know I'm going to get ROSC back on this patient. So we use our capnography. If I had to pick and choose between capnography or pulse ox, I'm picking capnography because it tells me so much more about my patient. It tells me how well they're ventilating, etc. So we use it a lot. So we did that. Perfusion. We want to make sure the blood pressure is good. So if somebody's still hypotensive after ROSC, we can give them some dopamine or some epi or norepi to just try to help the blood pressure be stable or maintain it. Look for your treatable causes. Do they need volume? Do they need blood? Are they septic? Are they having an MI? If they're septic, the one thing I can help out is by giving them antibiotics as soon as possible. Check their glucose, check their lights. There may be something there that may tell you about this patient. the moving on with Ross, for the rhythm, do we need to control the rhythm? So if I gave him amiodarone, and that got out of the rhythm, I need to hang an amiodarone drip, or magnesium, if that's what was helping this patient. Do we need to give them magnesium? As, depending on what the rhythm was. If it's a STEMI, they need coronary perfusion. Do they need antiplatelets? Do they need aspirin, blood pressure medications? So we may give sometimes STEMIs low pressure as well to help with the situation. If it's an NSTEMI, that's a non-ST segment elevated MI, it's going to be medical management. We're going to control their pain, send them to the cath lab for coronary intervention. People who have had an MI have a 30% reoccurrence of an NSTEMI. Amiodarone, your loading dose. So if the patient had a pulse, like maybe they're having runs of VTAC, pulse with a pulse, they're going to get a loading dose of amiodarone 150, slow over 10 minutes. And then the drip. So that's just our drip there is amiodarone 900 and 500. Concentration is 1.8 milligrams per 1 milliliter. And you infuse that every 6 hours, or for 6 hours. Then you reduce the rate to 0.5 milligrams per minute. By that time, you're out of here. So in summary, you want to use this consistent approach to your patient, that ABCD survey with your differential diagnosis, and use the history, the H's and the T's, and then that perfusion tank pump rate to help drive you down the pathway to treat that patient until we can get there. And do you have any questions? Okay. All right.